So I think most people are sent over. Good evening, ladies and gentlemen, dear colleagues. It's my very great pleasure to start with today's Neurooncology webinar on behalf of the Neurooncology section of the EANS and the section head, Matthias Simon. It's my pleasure to welcome you to this Journal Club webinar. Our focus today is on the role of extent of resection in the management of high and also low-grade gliomas, which we think is a very crucial topic as the balance between maximal tumor removal and preservation of neurological function remains one of our greatest challenges in everyday neurooncological surgery. So we have two speakers that will introduce some previously published work to us. One is Caroline Lindblad from the Karolinska Institute in Stockholm, and one is Matthias Demetz from Medical University of Innsbruck. And they too picked some papers, and they will very briefly present those to you. And afterwards, we will have a discussion involving Jiří Bartek, also from the Karolinska, and Matthias Simon from Bielefeld, who is also, like, as I mentioned before, the chair of the Neurooncology section, and myself. So I wish us all a nice webinar and nice discussion. Please don't forget to use the Q&A box if you have questions, and we will try to moderate and address them accordingly. So it's my pleasure to hand over to our first speaker, who can share his slides now.
All right, good afternoon, everybody. I hope everybody can see my slides, and it's my great pleasure to present you two papers about high-grade gliomas in this Neurooncological Journal Club. Today, we're going to talk about two papers. The first paper is from the RANO Resect group and about a new clinical risk model for post-operative outcome in newly diagnosed glioblastoma patients, which was published last year in Neurooncology. The RANO Resect group is a group of neurosurgeons focusing on the extent of resection and its impact on outcome in glioblastoma patients. The physicians come from both the US and Europe, from 7 different hospitals. In this paper, they included more than 1,200 patients from these 7 hospitals. Patients were classified into 4 groups in this paper according to their extent of resection. Class 1 was defined as supramaximal resection, defined as meaning all enhancing and non-enhancing tumor parts. Class 2 was defined as maximal CE resection, meaning all contrast-enhancing tumor parts were removed. Class 3 was a submaximal resection, and Class 4 was biopsy only. The authors correlated both extent of resection as well as other epidemiological and molecular features with overall survival. They found a significant influence of the resection classes on overall survival. The higher the extent of resection, the better the overall survival. Furthermore, MGMT methylation status, age, Karnofsky performance score, and post-operative adjuvant therapy significantly influenced overall survival. Based on these findings, the authors suggested a new clinical risk model. Patients who underwent resection showed a high Karnofsky performance score, where MGMT methylated and of a young age were classified as low-risk patients. Patients with biopsy only, elderly age, and low Karnofsky performance score were classified or had a higher risk for poor outcome. Differences in both progression-free survival and overall survival are shown in this Kaplan-Meier analysis, where patients with higher extent of resection and lower risk categories showed significantly better progression-free survival and overall survival. So in summary, we can say that this study had a very high patient number with more than 1,000 patients, a very strong endpoint considering overall survival, and they propose a very easy to use yet highly prognostic tool, which was highly predictive in their study. On the other hand, this study had a retrospective study design. So prospective validation of the proposed score and the findings is still pending, and further analysis of other molecular markers other than IDH1 and MGMT are still missing. So in conclusion, we can say that the proposed RANO risk score was superior predicting outcomes compared to other risk models, and it is easy to use and might therefore be of high clinical relevance, but however, external validation is still pending. Our second paper is about a multi-center prospective controlled trial about intraoperative MRI-guided versus 5-ALA-guided resection in glioma patients. In this study, 314 patients were recruited, and after exclusion of some patients for different reasons, 113 patients were analyzed after 5-ALA-guided resection, and 144 patients were analyzed in the intraoperative MRI group. If we compare the two groups, we see that the operating room time as well as the incision suture time was significantly higher in the intraoperative MRI patient group. However, there were no significant differences in the extent of resection between these two patient groups. The progression-free survival showed no difference between the two patient groups, and also the overall survival was not different between intraoperative MRI guided resection and 5-ALA resection. So if we take a look at the first primary endpoint, which was the extent of resection, we can see that 78% of the patients in the 5-ALA guided resection group showed a complete resection, and 81% in the intraoperative MRI group, so no significant difference here. Also, regarding postoperative tumor volume, there was no significant difference between the two study groups. Overall survival, as previously mentioned, was not significantly different between the two study groups. However, in subgroup analysis, the authors could show that MGMT not methylated tumors had a greater benefit from resection compared to patients who had an MGMT methylated tumor status. So in summary, we can say that this prospective multicenter trial again had a high patient number like the study before, over 300 patients, a very strong endpoint considering the extent of resection and overall survival in the two groups. However, this study had no randomization, and interestingly, patients with higher incidence of preoperative deficits were resected with 5-ALA guidance. However, in conclusion, we can say that the surgical results, considering the extent of resection and residual tumor volume, were comparable between the two groups and had no significant difference. And 5-ALA might have some advantages, especially economically and for practical reasons. And in this study, like in many previous studies, contrast-enhancing residual tumor volume was an adverse prognostic factor for both overall survival and progression-free survival in newly diagnosed glioblastoma patients. Thank you.
Thank you, Matthias. Matthias, would you like to now the other Matthias, would you like to take over the moderation, or should I go on and you take over the discussion?
I can take over the discussion. Maybe I'll do that.
Okay, so
please go ahead and introduce Caroline.
So now the second speaker is Caroline Lindblad, as I mentioned, from Stockholm, Sweden, who will now present us some literature on low-grade gliomas.
Hello, everyone. I'm delighted to be here to present in this webinar today. The title of my talk is Extent of Resection is Prognostic in Diffuse Low-Grade Gliomas. And I will present 3 papers that all of which try to answer the research question if the extent of resection matters following diffuse low-grade gliomas among adult patients. And the surgical hypothesis is that a larger resection is better when it comes to outcome. The first paper, I presume many of you are well aware of, is Asker Jakola's work from 2012, published in JAMA, a landmark study in which the authors compared 2 Norwegian centers. One center that tended to advocate for biopsy and watchful waiting following discovery of a presumed low-grade glioma, whereas the other center advocated for early resection. And what the authors could show was a very distinct survival benefit of early resection. And this was a very important study, of course, but it was presented before the modified and updated WHO criteria. And therefore, the authors undertook the same analysis in the same cohort in 2017, but now they instead updated and also added IDH mutation and 1p19q co-deletion status to all of their patients. And what we can see here is that they present a similar graph, a very similar graph to their first paper, but here they have adjusted for the molecular markers. And what we can still see is that there is a survival benefit of early resection for low-grade glioma patients. These 2 studies have very recently been followed up by a novel landmark paper, now published by Hervey Jumper and colleagues, in 2023 in the Journal of Clinical Oncology. In this study, the authors use 3 different groups. So one main cohort of patients from the University of California, San Francisco, and 2 external validation cohorts. One American cohort from Boston, and also the Norwegian cohort that I've described in the previous papers. And the main take-home message of this study is that overall survival is longer after more extensive resection than after subtotal resection of low-grade glioma, regardless of subtype. This is a very rich paper, and I will try to show some highlights from it, and then we can revisit other aspects in the discussion. But what the authors do first is that they use their main cohort from UCSF, and they undertake a type of analysis called recursive partitioning, which is a decision tree analysis whereby they can demonstrate predictors of long-term prognostic outcome. And what they show is that post-operative tumor volume, as well as preoperative tumor volume, molecular identity of the tumor, and adjuvant treatment affects prognosis. So, for example, among astrocytoma patients with a large residual tumor volume after surgery, they have the worst prognosis, while patients with a small preoperative as well as small postoperative tumor volume have a good prognosis. The authors elaborate on this by asking whether supramarginal resection or extended gross total resection is also a prognostic benefit. And what they can show across all of their molecular subtypes is that extended gross total resection is superior to gross total resection, which in itself is superior to subtotal resection. And last but not least, they use all of their 3 cohorts and now conduct a propensity score matched analysis. And this is important because it allows patients to be compared across centers. So all patients have a matched control in another center. And then they show that as the extent of resection increases, prognosis improves. So in this graph, the thick line denotes non-significant. When the confidence interval crosses this line, the results are non-significant. And what the authors can show is that when the extent of resection exceeds 75%, overall survival is significantly better for the patients. And then they show in a dose-response fashion that as the extent of resection increases, prognosis improves, both with regard to overall survival, progression-free survival, and malignant transformation-free survival. So taking all of these studies together, we have a large number of patients across several studies repeated over time, showing consistent and robust results. And I also think the last slide is important because it shows a clear dose-response relationship. This speaks in favor, of course, for the extent of resection hypothesis. A limitation in all of these studies that we can also revisit during the discussion is that all studies are retrospective in nature. And there are also some minor, I think, limitations on the statistical side in the Hervey-Jumper paper that we can also discuss further. I think also that there is an outstanding question that is maybe not conclusively addressed across all these papers, namely the importance of tumor location and the relation to eloquent brain areas. But summarizing these 3 studies, we can say that the extent of tumor resection matters for diffuse low-grade glioma among adults. An enlarged resection yields a better prognosis, and this is true both with regard to overall survival, progression-free survival, as well as malignant transformation-free survival. And then the authors, predominantly in the last papers, show that there are also other factors, of course, in play, including the preoperative tumor volume, the molecular markers, and also associated adjuvant treatment. Thank you.
Well, thank you, Caroline, for this very nice presentation. Also, thank you to Matthias for his presentation on extent of resection and high-grade gliomas. And I guess now it's up to me to sort of open the discussion. And so maybe the first step is to ask Christian or Jiri for any comments or any pressing questions.
So maybe I can start. Is it okay, Christian? Yeah, no, I think the presentations were really and I also think that you made a wise choice in choosing these manuscripts that you chose to present, because these are obviously, as you both mentioned, landmark papers. I maybe have some questions from Matthias, if it's okay for me to continue, but maybe Christian, you want to comment as well before
Please go on, continue.
Okay. So like obviously Caroline has told me what papers she wanted to choose, and I've known that. But Matthias, in terms of that, those that you choose, for instance, the Rano paper, I mean, you get from that you obviously get a clinical tool that you can but do not have to use, right? Do you use it? To be honest, is it easy to use?
I think it's very easy to use. To be honest, I don't use it in clinical practice, but I think we could start doing it because it's very easy to use. It has a high prognostic value, and I don't think that it addresses all possible parts. For example, like where is the tumor located? Do we have an eloquent glioma? Don't we have an eloquent glioma? What other comorbidities does the patient have? And maybe these are things that we should consider too, and not just the risk model.
Additionally, I think whenever you stratify data or progression in a disease, how to treat on very basic factors like age, I think it's necessary to do that. But on the other hand, so what you're doing now if the patient is 66 and not 65? Do you have to go, does it really go into the wrong way? Or if this is a decision tool on the other side, is it really then bad to do a surgery? So I think this is the problem that we have all the time. I think it's worth going after it and looking at it, but it's still trying to press a biological system into a metric one.
Exactly, I completely agree. And obviously the follow-up question would be, so Matthias, do you consider other factors to be relevant? I think Christian already touched based upon that, but what else could one include?
I think one thing could be the frailty scale. How frail is the patient? Because what we, at least in Austria, very often see are patients who are like 70, also sometimes 75 years old, and very fit patients. Sometimes they also climb the mountains in the background of Christian. So
Only Austria, only in Austria.
I don't think so. No, these are things. Also, some other comorbidities. How frail is the patient? How is he qualifying for, I don't know, adjuvant therapy after resection? Can we remove the tumor without any deficits? So these are things we should consider, in my opinion.
If you don't mind me asking, I think this is a very good paper with a lot of data, but can you please tell me how shall I apply it? I mean, the patient comes to me, I understand he has a Karnofsky index, he has an age, I know that before. Then we have this location and eloquence issue, which has been alluded to actually by Caroline in her talk, but that of course is also of relevance for the high-grade glioma topic. And now, what am I going to do? Will I go and not resect more carefully? Will I just do a biopsy? In which way shall I apply this prognostic scheme? I mean, it's interesting to know that I have a tool and I get a figure as to what the expected outcome is. But how shall I apply that in my clinical practice?
Well, the authors did not discuss that very clearly in the discussion. So I think considering that the extent of resection or biopsy only is already a part of the risk model, we maybe can apply it considering, I don't know, radiation therapy, chemotherapy, that we can say this is a patient 75 years old, has a very poor Karnofsky performance score, just underwent biopsy only because we have a tumor somewhere deeply located, that maybe in the future we can say this is a patient with very poor prognosis and we should consider or reconsider giving him any adjuvant therapy or just best supportive care, for example.
And what is novel in this score? Age, MGMT, degree of resection, Karnofsky. Well, what is novel in this score? What is the new information that I haven't been aware of before?
None of these single things is new to us, but I think the combination and the hazard ratios, the clearly significant influence, the clearly significant difference on overall survival in combination of these things is new or is novel.
I think it doesn't add very much to the everyday clinic decision, but I think it will offer, especially us, where we always have a discussion with radiotherapists, whether to treat a very fit elderly patient with combined radiochemotherapy. I think this can offer you some arguments in favor of treating patients with a more aggressive treatment. And I think that's one idea to follow. So say you operate your patients well in a well manner, and they do well, they have a very high functioning status afterwards. Then you can go, even in an elderly person, you could go for a more aggressive treatment.
Mm.
We have one question in the Q&A. Can a post-operative CT scan assess the extent of tumor resection compared to MRI?
I'd say no. I think we can all agree on that.
So additionally, Carolina, you didn't have to answer that much questions yet. I think the Dracula papers are great, and I personally think it's a very smart idea how they put together their patient cohorts. But that's also always a discussion concerning the quality of the research, since it's not a randomized controlled trial. So how do you convince somebody that's arguing it's not a randomized trial to believe the data we're seeing?
So this is a great question, and this is something that all of the different papers address. So all of them are retrospective. And the main argument is that there will be no clinical equipoise to undertake a randomized controlled trial. I didn't touch so much upon this, but you could see it in the Kaplan-Meier graph that the follow-up times are so long. So it's practically very unfeasible to undertake a randomized controlled trial, although that would be superior probably. So the Hervey-Jumpy paper makes a huge attempt of compensating for this with their propensity score matched analysis. But this is something that I've used this technique myself, and I think it's a great technique because it allows you to match patients in a nice fashion, but you can only match them based on variables that you know of. And the huge benefit of a randomized trial is, of course, that you also, when you just randomize patients, you match them also on stuff that you don't know about yet to be of importance. But I think that given the sort of the prerequisite situation, I think the propensity score utilized by the Hervey-Jumper and his colleagues is a very nice way of doing this. And I also think that the scale of their study with one cohort used for their initial analysis and then external validation also in two big cohorts, those are overwhelming data, I think.
Asking along the same slides, you mentioned that you had some statistical or concerns with the statistical methods of the Hervey-Jumper paper. I'm not a statistician, so
No.
maybe you're a good person since you said you have experience with propensity score matching. How good is this technique? I mean, is there in the overall in the statistical community, is there an appraisal of this technique, an idea how good it is? I wonder if I've posed the question the right way, but you probably know what I mean. I mean,
Yeah,
how much can I rely on propensity score matching vis-a-vis a truly randomized trial, vis-a-vis the standard retrospective evaluation of data that we have or that we often perform?
I think it's a great question, and I'm not a statistician either.
Okay.
But I've used it a little bit, and I think it positions itself between RCT and a retrospective study. I think the problem with propensity scoring is that in order to match patients, so you want to match them based on age and gender and other factors that you know to be of importance. But I think the problem is then that you normally diminish your study cohort to some extent because it's difficult to find matches of extreme patients. So, for example, it would be difficult maybe to find patients with really large tumors and match those perfectly with one another. So what you do when you do propensity score matching is that you have a cohort that you diminish into a sort of moderated cohort. And I think that makes the validity, the external validity of the cohort and of the results smaller, because I think you have a smaller population actually that you study that is more homogeneous, but you remove extreme cases to some extent. That I think is the practical consequence. So I think you can say this is something the authors argue, that in order to mimic an RCT, they use this technique. And I think that is a stretch because the propensity score is a nice technique, but it's not as good as randomizing.
Thank you. If you don't mind me staying with this issue of statistical methods, this is actually a question also for Matthias. In several of the papers, cutoffs were used to distinguish between several classes of resection. Some of these figures looked rather arbitrary to me. And so, Neurooncology has published quite a few papers, and there is this large group of subtotally, partially resected glioblastomas that somehow linger in between biopsy and a true complete resection. And then there have been several attempts to subclassify that. And I always found that the data was, well, not maybe of the quality it should be. And also in the heavy jumper papers, really, well, not figures 4.6 and other things. How does everybody feel about these cutoffs and how these cutoffs were achieved? And I mean, a lot of the patients that we resect, it's a small number. In a small number of patients, we have truly supramaximal rejections, very small number. And then we have a fair number of people who have complete resections, and then many patients are in this sort of intermediate group. How does everybody feel about that? Matthias, maybe we start with you. There's one cutoff in the ALA versus intraoperative MRI paper, I believe 0.17 ml. How did that cutoff come to happen? Do you remember? I'm not sure.
I'm not sure either. I don't think that the authors
0.175 to be complete is nothing, and residual volume up to 0.175.
I don't think that the authors discussed that. I think that might be some statistical.
I think it was rather arbitrary, or does anybody else remembers that differently?
I think we need a clear, we would be entitled to produce a clear definition of what is what. What is a gross total? What is a near total? Does it need a subtotal? So that's one thing we need to standardize somehow. And it's also one thing, if you do the statistics, I think as we had it before, you have to react to the data you're having there. And I think it's also with the classes you produce out of that, you prolong those uncertainties somehow. So I had the same impression, 0.175, how do you 1-2%, I can deal with that, but what is 0.175? How much tumor is 0.175 cc? What am I looking at if I look at 0.175 cc of tumor?
Yes, so I understand that you all agree in principle that some work has to be done in defining those cutoffs in that group of patients in between biopsy and complete resection.
If you allow me one more question, maybe
yes, of course, please.
To the more senior discussants in this round. So Jiri and Matthias, aren't you afraid, or maybe not, if you look at the RANO-RESECT paper, that you will be somehow limited to include patients in further treatment trials if they don't comply to the very good group? Or is this a goal we should actually pursue, that we say, well, the best surgical results should go into the treatment trials?
My answer,
yes,
yeah, obviously a very good question. I think this also illustrates a different point. I mean, when you think 5, 10 years, 20 years back, you had a case series of surgical cases published from one institution and a different one from a different institution. But now it's the sort of in the modern era, you have these big multi-institutional data sets and multi-institutional collaborative trials, and I think that's what you need to pursue. So you have more subgroups, right? So it's not like limiting to only including one subgroup of patient in specific trials, but defining more subgroups, I think, but making sure that you still have a broad network so that all patients are sort of allowed, or that it's made possible for them to take part in different trials.
I think, Christian, that your point is very well taken, and you're saying something in a very precise manner that I tried to allude to in a more diffuse way. There's a fairly large group of patients. I mean, we're not leaving glioblastoma behind because we want to. There are always reasons for that. This is a large group of patients that have subtotal resections, and this current focus of complete or supramaximal and so forth, and sort of distracts us from investigating these patients, and that of course includes that we do not include them in clinical trials. I think this point is very well taken.
We have one more question in the Q&A. I think that question, as a matter of fact, goes straight to Matthias Simon. In a left-sided, low-grade, large insular glioma, healthy young patient, what would be the recommendations based on the studies? Is there a prognostic difference between GTR and only a 50% resection?
I think, I mean, we have talked about that we do not talk so much about location. Now we are talking location. And of course, if we break it down to certain tumor locations, we don't have good data to say, hey, for example, in insular gliomas, it makes a lot of difference to take out 50% or 100%. I think in the subgroup of insular gliomas, we can rediscover all those relations between extent of resection and survival that we also see in all other groups of gliomas. So I think it is safe to assume that the more you take out, the better the patient will do in terms of survival. I think an honest appraisal of insular surgery is that if you're too aggressive, your deficit rates will go through the ceiling, and you shouldn't do that. So in this case, I think I would definitely do more than 50%. I would try to do something like 70+% or more. I think I would pay attention to the extra insular extensions of the tumor that can be removed much more safely than the tumor in the insula itself. And well, sometimes it is possible to have an almost a gross total resection. In many instances, it is not probably safely possible. I hope that answers the question here. And yes, I shouldn't talk about percentages. I should talk about volumes and ml. I think this is also something that we see in the literature and the papers that we just discussed, that we should not talk so much about percentage of resection, but rather of how much residual tumor was left.
There was also one other question before. I'd like to rephrase a little bit, and it goes towards Caroline. How do you deal with, given the papers that you presented, for example, with an oligodendroglioma that turns out to be not perfectly resected? What's your idea of further treatment? Do you go in again? Does this is this a decision connected to further molecular markers, to imaging only? How do you stratify your patients given the papers you just showed us?
So this is something that is in the Hervey Jumper paper. They address gross total resection, also subdivided on oligodendrogliomas. They don't address a second surgery, but what they say is that, interestingly, for oligodendroglioma specifically, there is no significant difference between extended gross total resection and gross total resection, but there is a clear survival benefit between gross total resection and subtotal. So it's better to remove all of the oligodendroglioma, but then they don't really comment upon other risks associated with the second surgery, infection and new deficits or something like that. So they don't really account for that, but they rather focus on the first surgery.
Maybe a question to Caroline and Matthias. And given the fact that there's an emerging bulk of data that extent of resection somehow plays a different role in oligos versus esters, at this point at your institutions, do you already apply that idea in clinical practice? Are there any thoughts of, let's say, getting a biopsy first, for example, in a difficult location and then go for the surgery? Or is this something that, well, we all have in mind, but we'll see how it goes and we just wait for more data? What's the general feeling at your institutions? Yes.
Do you want to start, Carolina?
Yeah, this is probably a question for Jiri. Maybe my impression is that we, because we don't know, most of the time we don't know beforehand, even though there are radiological signs indicative of oligodendroglioma. So I would say that in our department this far, we aim for extensive resection of the low-grade gliomas. But I'm happy for Jiri to fill in on this. Okay, great. Thanks.
Okay. Matthias and Christian, how do you do this? How do you feel about this issue in Innsbruck?
Same thing here. I would like to pass the question. My telephone joke.
Don't be shy, the two of you. No, generally we rely on the pre-op imaging, and we don't do biopsy in every low-grade glioma patient just to figure out if it's an astro or an oligo or something else. So generally, if it looks like an oligo, we might adopt the strategy of being a little more aggressive. One can always argue also frozen section, which we usually rarely do, but we don't do biopsy in all cases routinely before. If only in cases where it would make a difference, like very large, eloquent tumors, where you say, well, if I would treat an oligo, I'd be even more aggressive, then it can make sense to do a biopsy upfront, but not as routine.
Maybe nanopore sequencing, something like that.
If we arrive there, so we usually
maybe interesting idea.
We're setting that up with a liquid biopsy very soon, and I think that will be a total game changer if it works as reliably as I think. And as I'm always convinced by the people who are very deep into that field. I'd say this is a big game changer. If you just do a lumbar puncture first and then you have an estimate what you're looking at, I think this will change our way of treatment, and it will also change our way of scheduling. It will also might sometimes relieve some pressure from clinical scheduling as well, if you already know what it is.
Jiri, I think Jiri has a comment or question.
Yeah, I have a question, more like a general question to both Caroline and Matthias, and no, again, the presentations were really good, and you were obviously studying up on your individual fields, and my question is more like a broader one. So what's the missing link? What's the next step? If you were to design a study now within the resection and low-grade glioma and the other field that Matthias had, high-grade glioma resection, what's the next study that needs to be done? If you had all the money and financial power of EANS and EANS combined, you can.
I think for low-grade gliomas, it would be to find a better imaging tool so that you could discriminate the tumor extent perfectly using the pre-op MRI. Because I think it's a huge limitation that in the Hervey Jumper paper that they cannot really specify exactly what entails an extended gross total resection. I guess it's beyond the border of flare hyperintensity, but I think like the best MRI sequence for low-grade gliomas, that would be my investment.
Very good. So you don't think a RCT? I mean, you obviously touched based upon this already, that an RCT and biopsy versus resection is feasible.
No, I think it's it's likely too resource demanding, I think.
And probably difficult to enroll patients in, right? Considering the vast
Yes,
number of
exactly.
data available. Yeah.
I'm very, very convinced that you will not be able to pass this through an ethics board.
Mm.
Agree.
Yeah.
And also from clinical practice in terms of tumor boards, if you biopsy a low-grade patient that is over 40 years of age, then your radiotherapist will already be ready loading his guns.
Mm.
And
Right.
Matthias, have you any suggestions for something?
I'll go with Caroline. I like, yes, of course, the imaging question I think is central to all what we discuss here. We measure extent of resection based on usually MR imaging, and starts with the high-grade gliomas, contrast enhancing versus non-contrast enhancing tumor. It is one thing to have the radiologist tell you, oh yeah, this looks more like tumor than infiltration zone, but what is it really? And in the low grades, it's even more complicated. And then I stay with with this cutoff topic. I think that there's a large number of patients undergo subtotal resections, and I personally think that they benefit from some debulking because that enables them to undergo further treatment. But this is somehow not in our focus at this point. This is where I would look into imaging, and then the second question.
And then Matthias, do you have any suggestions to a study that should be done in your field?
I think what would be very interesting if we could define a better margin between the infiltrating tumor tissue and normal brain tissue, because this can be very, very difficult sometimes, and maybe we wouldn't need to do that supramaximal resection anymore, because we could distinguish between really also non-enhancing tumor parts and normal brain. That would be interesting.
The next level 5-ALA.
Yeah,
Might be some kind of, I don't know, subvisual fluorescence of 5-ALA. That would be very interesting to work on that.
Well, I think it's about time to wrap it up.
Okay.
So
Are there any more questions? Let me see.
No, just a comment, no questions in the Q&A. They're all been answered.
All right.
We haven't been talking about the second paper of Matthias, and I'd like to end this probably on a very quick question to everybody, one after the other. So Caroline, 5-ALA or IMRI?
I'm biased. We don't use intraoperative MRI really routinely, but we do with 5-ALA, so I would stick with that. We also had Walter Sturmer here presenting not long ago, so I'm heavily pro 5-ALA.
Matthias?
Which Matthias?
Yeah, difficult. You first.
Me first. 5-ALA for practical reasons. Intraoperative MRI is a bit of wishful thinking for us right now, so I have to stick with 5-ALA. Also, remember, but when I was in Bonn, we established our new MRI, and that led to not being able to do any other case in that operating theater on that day anymore. So intraoperative MRI is a very nice technique, but if you can get the same result in a more practical way, maybe this is the way to go.
Other Matthias?
I completely agree with that, because what we have seen from this paper is that we have similar resection rates and a similar overall survival with 5-ALA and it's much more cost efficient, and also for practical reasons, I would go for 5LA.
Yuri?
Yeah, so Caroline is not completely honest. Actually, when they build a new hospital, the floor of the OR rooms at our hospital was not thick enough, so we don't have an intraoperative MRI. It makes it very, very easy. So we are already pseudo randomized to one group, so 5LA.
Okay. So
Your personal opinion, Christian?
my personal opinion, 5ALA for the very same reasons that you just mentioned, because I think the MRI is a nice tool. I think we still don't know what it's all capable of, but it's 5ALA is much easier and it can do 3 5ALA cases in 3 ORs next to each other if you have the microscopes. You never can do 3 high-grade gliomas in the
Yes.
MRI.
Yes.
Okay, then. So I thank you all for the
That's it,
presentation.
Christian?
I think we are about to wrap it up, aren't
Okay.
we?
Then I guess thank you to everybody. Thank you in particular to the speakers. Very good, very nice, very enlightening presentations. I think we had a good time and discussed a few important issues. Okay, Christian, do you want to send us all home?
Yes.
Okay.
Have a nice evening. Thank you.
Okay, thank you, everybody. Bye-bye.
Bye.